Hi there, and thank you for joining us for this UCF AAC ECHO series, AAC for Adults series. We're happy to have you join us here for this recording of the 5 Ps of AAC assessment. Unfortunately, we were not able to provide this live due to a hurricane here in the Central Florida area, but we hope that you will find this recording helpful. So my name is Punam Desormes. I'm a speech-language pathologist, and I'm also a clinical instructor and faculty member in the UCF, University of Central Florida, School of Communication Sciences and Disorders. I'm a RESNA certified assistive technology professional, and I'm also a liaison to our FAST ARDC, which is the Florida Alliance for Assistive Services and Technology Atlantic Region Demonstration Center. It is one of the state AT centers supported by the AT Act here in Florida. My disclosures involve my financial disclosure of employment by the University of Central Florida as a full-time faculty member, but I have no other financial ties to any of the products referenced or systems referenced today. I'm an ASHA member, a RESNA member, and a SIG 12 member. So today, we hope that you'll be able to achieve these 2 learning objectives to identify 2 or more aspects of the 5 Ps of AAC assessment model. And secondly, describe the role of the speech-language pathologist in the AAC assessment. If you are not a speech-language pathologist, please feel free to adjust this second objective and think about what might be your role in this process. So here you will see my 5 Ps of AAC assessment. Clearly, I'm into the P thing because my name is Punam, but also it's because I realize that in providing clinical instruction and supervision to pre-service clinicians through our UCF Communication Sciences and Disorders Clinic, I really needed to lay out a clear plan that students could follow visually as well, and it never hurts when it has a cute name, in my opinion, a cute name with 5 Ps. And so you'll see here that we have pre-plan, plan, prepare, perform, and prescribe. Now you may notice that the first 3, pre-plan, plan, and prepare, sound really similar. And I do have some explanations of what these are on the right-hand side, and you also will be going through them with me today during this recording. But you may find that if you are not providing services as a clinical supervisor and you're not working with graduate clinicians, then you might not find that you need this breakdown of those top 3 separately. But I must tell you that I definitely did it on purpose for what I'm providing at the UCF Communication Disorders Clinic. The AAC evaluations and assessments that we're doing with the students really require us to have a pre-plan, plan, and prepare all 3 sections. So that is on purpose for the type of services that we're providing here and the students we're working with. So let's start with P1, pre-plan, which is create a process. So as discussed briefly just now, it was really important that we came up with a process that was clear and that we were using vetted evidence-based practices and resources. So part of that pre-planning kept all of those things in mind. So as a supervisor, I'm coordinating meetings with my team, which may be the graduate students, but also you might be coordinating meetings with other providers that are working with that client. Always best if we can get others on the team involved in this AAC assessment process. I've had some individuals even come into assessments, the occupational therapist or physical therapist with me. Sorry about that. Billing, we need to really think about billing for the actual assessment. We use our electronic medical record system here called TheraPlan. And we had to figure out how we were going to bill for these AAC assessments through TheraPlan and what codes we would be using. We use ASHA's best practices on that. You can find information on the American Speech Language and Hearing Association website about billing for AAC assessments. And how to make sure you're following the right methods to bill, especially if your assessment is across multiple sessions, which ours are. They're typically two-hour evaluation sessions. So CPT codes to be using for billing for that, as well as coverage codes for speech generating devices if they are recommended. Those HCPC codes, we'll get into that a little bit later. We also wanted to have a good process for our documentation with our intake forms, our testing, our report templates, and as well as the timing of the assessment. As I mentioned, we do two-hour sessions typically. So speaking of vetted resources, we really don't need to reinvent the wheel. Here at the UCF Communication Disorders Clinic, we are using a pretty extensive, long, narrative-based AAC assessment report template. And if any of you are speech language pathologists, you probably remember being in graduate school and kind of having to do a long form for everything when you were writing your assessments or doing any of your documentation, just so you knew exactly what it would need to look like and all the parts and pieces that should be in your reports. So we do use that here at the AAC during our AAC assessments. However, if you are not in a university setting, then you may find it more efficient to use some of the templates that are provided by the AAC and durable medical equipment vendors. Some of them also have templates right online now where you're submitting everything online and using their text boxes. The most important thing is you want to just make sure whatever method you're using, that it has all of the parts and pieces and all of the aspects that are needed in a quality AAC assessment, especially one that's going to go to funding of a speech generating device. So you can find all the information about what needs to be in there, and we'll discuss some of that today. But at ASHA, there's also some other great resources down here at the bottom. We have the AAC funding.com, Practical AAC, lots of really great information about best practices and resources there from vetted and well-known researchers and individuals in our field. Sorry about that, keep clicking forward. Augmentative communication consultants and the RERC are just a few more resources. Again, I mentioned being a liaison to our state AT center, one of our state AT center sites, which is again called FAST here in Florida. So that is an amazing resource because your state AT center that's supported by the AT Act can provide demonstrations, trainings, loaner devices for assessments, and can even guide you through the Equality AAC assessment process. That's what they're meant to be doing, providing training and demonstration and loaners to clients, caregivers, but also us as professionals that are conducting evals. So don't forget about them as a great resource. Find your state AT center. And of course, we really need to think about funding. We really can't go through this process without being aware of what the client needs, what their intentions are for that assessment that they're coming in for, what they're looking for, why are they there, and what coverage they have, because we can recommend the best system that meets all of their needs to help them access communication in all of their various environments. But if they can't get their hands on that system due to a funding issue or an authorization issue, a trial requirement issue that we're not aware of, then we really have done them a disservice. So skipping down to one, trial requirements. Some funding sources require a specific trial period, which is either 4 weeks or 3 months, but you might also recommend a trial to your client because your client needs to have some extra time with that recommended device and ensure that it's the correct one. And going back up one, we're talking about adults here, but we do have adults that are still in the school system. So if you are working within the school system, connect with your district AT personnel, your AT experts in the school system, and see what the process is there and what systems they can give you to conduct an AAC evaluation. And so loaner devices that they have on hand, they might be able to connect you with the vendors, and also the process and best practices. So whenever we're going through this pre-plan part of the 5 Ps, I always try to connect the academics to the clinical practice for our students. And so I refer them back to their AAC course, and the book that we use in our course here is Cook and Hussey's Assistive Technologies, Principles and Practices. And they have this great flow chart. And so I usually go through this with the students, and we look at this flow chart and say, okay, this is where we are in this process. So now we go to our actual planning. And that is client-centered, client-focused. So we're making a plan based on what we know about this client and what we're going to find out about this client. So as we look at what we know, we probably have an intake form. We have a really great intake form that we use here, 2 of them. We have an adult-based AAC intake form and a pediatric AAC intake form, where we have gone through and asked individuals or their caregivers and their family to fill out information that's general speech language, medical history, background information, but also has sections for them to tell us about other providers that they're seeing, and to tell us about some of their AAC history or how they're communicating, if they haven't used any AAC supports, how they're communicating with their caregivers, their family in the different environments that they're in right now. So that's paramount. We want to know how can we help them with inclusion in their different environments? What are they being included in? What are they being excluded from right now that they want to be included in their different daily life and environments? And what are their needs? So again, our intake form has a section on service history for different providers that they're seeing, as well as AAC system history with specifics. And we always go through and, if possible, have at least a short phone interview with the caregiver or the client or both, so that we can get some extra information and clarify things. So that's on this next slide. We don't want to wait till this session to do that first interview, even if we're going to do a great non-standard assessment or questionnaire, but we want to get some more information beforehand so we can be well prepared. So we might want to clarify information and ask for details. That happens a lot. We will have information on our intake form that says something maybe a little bit vague, like used an AAC device at school, but now they're not at school anymore and don't have it. But we don't know what that was. We don't know if it was a high-tech dynamic display device, or was it no or mid-tech, aided or unaided? If it was high-tech, what software was it? What hardware was it? What was the grid size? So once we get that information in the intake and we do this interview, we can have a list of the questions of things we need clarification on. And then based on their responses, we can ask for more details. Many of the clients and their caregivers may not be aware of some of the specific vocabulary we use to discuss these systems. So they might not know the name of the hardware or the name of the software or all of those details. But with some guiding questions, sometimes we can get a little extra information. We also request that they bring things with them to the assessment. So if they have existing systems that they're using, highly preferred items, stimuli that they like to talk about. I had somebody before that really liked poetry, so they brought that in to discuss and show us during the AAC assessment. We can always ask them to do that. And then we want to reiterate the purpose, because many times individuals and their families are really not sure what is involved in an AAC assessment and how it may be similar or different from a speech language assessment. So I always say it is a speech language assessment, but it has an added component of looking at augmentative and alternative communication to see if that would benefit the client and see if they need that. So I always reiterate that purpose. So speaking of that, all the things, we want to gather all the things in our plan. We want to plan to gather all the things, I should say. So that would be the AAC systems, no tech, mid tech, high tech, that we're getting from our AT centers or our vendors directly, or the clients bringing in something they've been using, stimuli and activities that they like to do. That could be, literacy activities, and games or other relevant things that we can engage them in during the assessment, especially during that trial period of the systems, when we're doing the dynamic assessment and we're giving them an opportunity to try out the devices. We want to have something relevant for them to do and be able to then use the system to access that so they could see how it would work in their real life. And that takes us to P3, which is prepare. Gathering what we need, which we've kind of already started to touch on. So to go back to the fact that this is a speech language evaluation with an additional component of AAC, that means that we definitely want to conduct formal and informal assessments, if possible, to gain an understanding of their receptive and expressive language and their functional communication. That information is needed for the speech generation funding report, speech generating device funding report, to make sure it gets funded, that they're going to be looking for that information. But also we can gather information about our clients' current strengths and areas of need when it comes to their expressive and receptive language and functional communication skills. So we might not always be able to conduct a formal assessment, a standardized assessment that is really going to give us a lot of valuable information. So we might be making modifications or settle on doing some informal assessments, but it's really based on the client and what is going to give us some really good data and information to guide our recommendations. So here are some examples: the PPVT, the TASK, the DAG3 communication matrix, the functional communication profile. Now, of course, with those standardized assessments, we have to think about whom they are normed on and if that fits our client and their diagnosis, which is usually not going to be the case. So we might be making modifications. And as long as you're reporting all of those modifications in your narrative section of your assessment, when you're talking about the results of this testing, you'll be good to go. So for example, the test for auditory comprehension of language, or the TACL, might be used to get some understanding of their auditory comprehension or receptive language, and maybe it's modified, but if we do that, making sure we're noting that in our narrative. So students always ask, well, I thought we have to give it exactly how the test says, and can we make modifications? And it's really important that we know how to administer a test correctly according to how it should be administered, but also knowing when and where we can make modifications and how we report on it. So again, I'm always just sharing with students, as long as you're saying exactly what you're doing that changes that assessment and are noting that you can't, that you need to interpret the results with caution based on these modifications, then you're good to go. So that can really support this assessment. You also want to make sure that you have a communication needs assessment and a communication environments inventory, meaning we need to know from this client, where are they communicating now, with whom, and what do they need? What functions of language and situations do they need to be able to communicate better in? What is blocking them right now? What are they unable to access and be part of because they don't have a system that helps them to do that? And of course, feature matching. So let's go a little bit more into that. So there's a lot of feature matching comparison charts. And the idea here is that we want to figure out what features are needed in this AAC system, what the client needs. And then when we do our trials of our devices, noting what features the devices have and matching that, making sure that the system that we're recommending has those required features, or at least majority of those required features that that client needs. We never want to be trialing just one system because we know that rep and they're great to work with and they give us the device and it's at our fingertips. No, it's not about that. It's about what does that client need and what features are going to help them to communicate across environments. I also like the Tobii Dynavox Augmentative and Alternative Communication Needs Assessment. So again, this helps you to get an inventory, frequency, communication partners, and if those modes that they're using are effective right now. Also, when we're conducting this assessment, we like to use that framework of the AAC competencies and looking through the lens of the AAC competencies. So as we're doing our trials with our AAC systems, I encourage the students and guide the students to make sure that they're taking data and making clinical observations in all of these competency areas. So let's look at operational competence, and let's make sure we're documenting with the system that they trialed. Are they able to power on and off? Are they able to navigate it? How are they able to access it? How are they operating this system? And is it working for them? With their linguistic competence, how is the system working for them when it comes to their language use? Are they producing one-word utterances? Are they putting symbols and words together? Are they typing? Are they using pre-stored messages? And for what functions of language are they using it? Strategic competence and social competence and emotional competence too. So just always kind of having that at the forefront and foundation. As we do those trials with the AAC systems, no tech, mid-tech, high-tech, whatever they are, we of course are being cognizant of the fact that we are showing these clients something they haven't seen before, likely something they haven't used before. So we wouldn't put a system in front of anybody and expect them to know exactly how to use it and start efficiently communicating. So it's really important that we do a demonstration of the system to the client and the caregiver, give them an overview of this is the hardware, this is the software, this is how you can access it. Here are some of the things that we've programmed in there because we've learned about you and we wanted to have some relevant vocabulary in there. So we're going to give them an overview and we're going to do a lot of modeling on our end as we communicate in using the system. After that, when that client is given an opportunity to try the system, to trial the system, then we might be using a hierarchy of prompting. So I definitely do this during our AAC assessments too, not just in therapy. We're using a least to most prompting hierarchy, and this is one that UCF AAC Collaborative made, follows evidence-based practice, and very similar to a lot of AAC prompting hierarchies that are out there. But, really make sure that we provide the individual an opportunity for independence. If we don't give people extended wait time and an opportunity to try something on their own, we'll never know what they can do. So wait and listen. Then maybe we're providing a verbal cue, maybe some gesture cueing, maybe some modeling. And I really refrain from any type of hand over hand assistant. It's usually just not necessary and really can be invasive. So as we're doing our trials with AAC systems, I'm telling the students to make sure they're looking at those competencies, taking data on what the individual is able to do when it comes to those competencies with the trial system, and then provide this hierarchy of prompting and note that. So it is completely okay, appropriate, and frequently the case that the individual is not, again, going to know exactly how to use this system efficiently and perfectly when they're trialing it during an AAC assessment. So in our report, we are noting demonstration was provided, aided language input was provided, and at least to most prompting hierarchy, and the client was able to X, Y, and Z related to the AAC competencies with maybe a verbal cue or gesture cues, and that's completely fine. So we kind of, as we talked about these previous Ps, we definitely have touched on the performance aspect of it, because you can't talk about all that planning without getting into the performance, because that's the fun part. So perform P4, conducting the assessment. One thing I always tell our students to do in the beginning is don't get so excited that you have those devices ready or those assessments ready and the client comes in and you just go straight to it. Let's make sure we create a rapport and we provide an agenda. Even though we've talked to them and had an interview beforehand, maybe over the phone, and we've reiterated the purpose of the AAC assessment, they still might not know what to expect when they come into those sessions. So at the UCF AAC or UCF Communication Disorders Clinic, our AAC assessments are typically conducted over two-hour sessions. Now, these are not 2 hours in which the individual is just being tested and doing trials the whole time. There's time for rapport, there are time for breaks, there's time for additional interviewing and what have you. So it's really important that they're aware of what to expect, what leeway we have, and that we create a rapport with them before we go straight into that testing. We also talked about the skills and needs assessment a bit before with some of the forms that we shared. We talked about some of the standard and non-standard testing that you would want to include. And then we've been talking about our trialing of the systems, which is really our dynamic assessment, where we are using those AAC competencies again to guide what we're observing as we provide devices to trial in the context of functional and relevant activities. When it comes to some of the assessments, we talked about the communication matrix. Here is a printout, an example printout of the table or chart that is a result of the communication matrix. I really love this because it gives a really great view of the individual's current communication from pre-intentional behavior that we have over here at level 1 through intentional behavior, unconventional communication, conventional communication, concrete symbol use, abstract symbol use, and language when it comes to creating longer utterances and combining words and symbols. So the communication matrix, I think, is wonderful because it really gives individuals credit for all the ways that they're communicating that may not be typical or conventional ways of communicating. So it gives credit for body movements and helps us to document body movements, eye gaze, facial expressions, use of sign language, braille, maybe 3D objects or pictures and symbols, or even AAC speech generating devices. So it really gives a lot more information than doing some of the standardized tests that aren't really giving credit for these other modes of communication. And then as you go from left to right in the communication matrix, it helps you to assess and document how they're communicating, not just through these levels, but across functions of language: refusal, requesting, social, gaining and sharing information. On the top right, you also see one assessment we talked about before, the test of aided communication symbol performance, that can help you to determine appropriate grid size and categorization skills and some syntax and semantic skills. It's also so important that we look at the whole person. We want to make sure that we are in our skills and needs evaluation looking at their motor skills, their sensory processing skills, what works for them as far as sensory processing in their environment, and their hearing and vision. So we might not be formally testing these things, but we definitely want to call upon our other providers, our OTs and our PTs and the clients themselves and caregivers to give us information about past hearing and vision testing, also how they're able to ambulate and access their environments around them from a motor perspective, because that's going to really guide how they can access their AAC systems. So when we look at all that, we're able to then prepare the devices that we want to trial, or the AAC systems that we want to trial, whether that is an eye gaze board, a mid-tech system, high-tech system like the Proloco for text that's right here in the middle, in which they're using an alternative keyboard with voice output, quick phrases, maybe some switch access, head tracking, or eye gaze. So once you learn about that client, you can then prepare those systems. So we usually trial at least 3 systems, and those are typically across varying companies. So we're making sure we're not just using one vendor. Love all our vendors, but we're not using just one. So we want to make sure we're trialing a variety of things to ensure that we are making a recommendation that's valid, because we've tried a variety of things and the client has been able to demonstrate which works for them best. So knowing about all those needs helps us to guide this. Do we need to get some switches and make sure that we're providing options for switch access with auditory feedback? If they're using eye gaze, what are their visual skills? Does it need to be right in midline? Do we need to mount it a bit to the right or left of midline if they're using their peripheral vision? So these are some of the things we're thinking about when we're picking devices to trial in the AAC assessment. Again, please remember to also connect with your AT centers from your state AT centers. We have ours down here. Here's our FAST center demonstration room, so that you can get your hands on these systems before and prepare them for the AAC assessment. As we were talking about that, we want to not forget about some accessories as well. In addition to switch access that we talked about, or head tracking or eye gaze, you might be needing to trial a key guard or look at some other mounting options. So again, your vendors can help you with that to obtain that equipment so that you can have them as part of the trial. You really don't want to be making a recommendation for something that you haven't trialed and the client hasn't trialed. Once we gather all of that stuff and we have programmed the systems, we want to create relevant activities to target these AAC competencies and give the individual an opportunity to trial the devices, do that dynamic assessment. So it's really important that we create opportunities, and we can do that in a variety of ways. Maybe we are engaging them in playing a game. Maybe they're sharing information and thoughts, some past experiences. Maybe they're engaging in some activities of daily living and talking about that. Maybe they're asking or answering questions. Maybe we're doing some greetings or personal information sharing. And maybe we're doing some shared reading or other literacy activities. Maybe we're just giving them an opportunity to explore the system and explore that access method. It's really, really important that we provide a variety of activities that can help elicit different functions of language and document what happens, so that we can look at that feature matching chart, look at those needs, and make sure we're making a recommendation that really fits what they need. So as we're going through this dynamic assessment and the individual is trialing the devices, I always want to think about some of these points here, things that I want to keep at top of mind. Those are making sure that I provided the most robust system that I can. I want the client to have access to as much vocabulary as they can scan in whichever way they're scanning and access. I want to think about the organization of the vocabulary. Did I provide different organizations of vocabulary that were maybe semantically based or syntactically based, a mixture of both? Or maybe it has predictive language or other features. Did I give them an opportunity to try these different organizations to see what fits best? Did it have the vocabulary they needed? Core and fringe vocabulary, equally important. Again, did I make sure that we provided various modes of access to see what mode of access worked best for them? Did we make some adjustments to maybe grid size, maybe to the color coding or the high contrast color coding of the symbols or photos? And did we think about the environments in which they need to use the system? So sometimes we're going to gain this information in that first session off that first trial, and then need to change up what we do in that second session to those subsequent sessions. That's why I really like to have more than one day that I'm doing this assessment, because we learn so much about that client once we actually see them, and can then make adjustments in the next session. Might not be what we expect, but it's always exciting. So as we're looking at the different systems and what we're going to recommend, we probably all have heard about making sure the client has access to a robust AAC system. And what does that mean? So one of the things that I loved is something I learned from Kate Ahern. in a Talking with Tech podcast with Rachel and Chris. I don't know if you've heard about that podcast, but if not, it's a great one to listen to, Talking with Tech. And she described what she considers a robust system, and she called it a mega PC, which I really, really loved. So mega PC stands for motor planning. So does it have a motor planning aspect to it? Is there some consistency? Does it have expandable vocabulary? Does it have access to grammar? Does it have an alphabet or a keyboard? Does it have pre-programmed whole messages for efficiency? And does it have core words? And I would say core and fringe vocabulary, of course. So if the system is a mega PC, then you know it is robust. So I definitely love that and wanted to share that resource and acronym for you all. So lastly, P5, we end with prescribe. So it's time to write that report. This is what it feels like sometimes when we go to write that AAC assessment. We have worked so hard to make sure we are providing a speech language AAC assessment that is covering all of the bases. But how do we document this? So it's really important, again, that we go to our vetted resources. Maybe you're going to use an online system with a DME vendor company like Tobii Dynavox or Saltillo or Control Bionics and use their online templates and submissions. That's totally fine. And they are going to help you with making sure you're using the right codes as well. Another place to go to make sure you're using the right HIPC codes when it comes to recommendations of a high-tech speech generating device is ASHA. They have great resources there to make sure that you're picking those right codes. So E2510 for a high-tech speech generating device, E2512 for mounting, E2599 for accessories. And just rely, once you've come to that recommendation and you're going to write that report, really rely on your vendors. I do. They help me to ensure that I'm writing out the names of things and putting the appropriate codes on everything. Those vendors are also going to help you with their individual forms. There's usually a client information form, an assignment of benefits form, some HIPAA forms, and equipment selection sheets that you're going to need to fill out that are specific to the recommended device. And of course, your certificate of medical necessity, which is your prescription from the referring provider, the physician, to ensure that they are okay with that recommendation and understand why it's being recommended and why the system is a medical necessity for the client. So you've turned all your paperwork in, and usually what happens is that that vendor company is going to look through all of the paperwork, the AAC assessment, all those additional forms, and they're going to help you with any like tweaks that you need to make, things like that, which are usually really great recommendations in my experience. And then they're going to work directly with the funding company to get that device funded. Sometimes, as we mentioned before, if a trial is needed because that client needs more time before it is actually recommended with the system, or because insurance requires it, they might get a trial device from that device company. Sometimes that does need to go through insurance to get the trial device. And then maybe they're coming to see you or their private speech language pathologist to do further trials with that system. If that occurs, usually you write an addendum report after the trials are completed that's saying, yes, we concur with the original recommendation, or maybe here's some tweaks, some other things that we'd like to recommend instead, and all of that gets sent in. After they obtain the device, so important that we provide them with fitting and training. So many people end up with a beautiful speech generating device at their doorstep, and they have no idea how to set it up, and they have no idea how to use it, and their family members don't know how to be good communication partners to them. So whether we conduct the fittings ourselves as the evaluating speech language pathologist, or we help guide other providers like their private SLP, that's totally fine. We just need to make sure that we meet with them and help them set up their system. One thing that I do is we always take a backup of the recommended system from the AAC assessment, from the trials. We make sure we back that up. And so usually then when they get their device, we can just pop that slightly programmed vocabulary into their new device, and then we can further program it to their needs, because usually during our AAC assessment, we've done a little bit of programming and maybe a few adjustments. So we want to do that. And we also want to help train their communication partners and other providers on how the system is set up, some basic programming, and provide them with resources and connect them with their local vendors. Also, so paramount, so important is collaboration for that implementation. A lot of times I'm helping to connect the providers that were maybe part of the assessment with me, the PT or OT that I got to work with if we were very lucky, or at least connecting with them to make sure we're collaborating on and helping with implementation across environments. So that follow-up is so, so important. Lastly, we will end with a bit of a case study. Unfortunately, we're not doing this together in the normal environment we wanted to, with some back and forth. So I'm just going to present this and then have you all on your way. Let's explore the example. So we had a 23-year-old male Caucasian patient. He had the following diagnoses: spastic quadriplegic cerebral palsy and epilepsy. He had outpatient AST and PT, and is part of an adult day program, and came to us specifically for the AAC assessment alone, since he already had a speech language pathologist that he was working with, who actually referred him for the AAC assessment. That client was currently communicating via eye gaze, vocalizations, facial expressions, some motor movements of his arms, especially his right hand, because he often was using a step-by-step multiple message communicator that his providers were recording messages on, and he was activating with his right hand. So again, for his system history, past experience with switches, and some choice boards that he was accessing either by touch or by eye gaze. He still had a lot of needs and a lot of environments he wanted to be able to communicate in beyond what he was able to do with his current modes of communication. And those places included his adult day program, his home, in the community with his peers. He needed some alternative access. He needed some auditory feedback, photos and symbols. He needed to be able to combine words, but also have some quick pre-stored messages. And he needed to be able to communicate about for a variety of functions of language. So we conducted the communication matrix and some other informal observations. And we trialed the eTran eye gaze board with some highly preferred topics on the different quadrants that he was looking at with eye gaze to communicate. We also trialed the Forbes AAC WinSlate 12D with switch access, Tobii Dynavox i16 with gaze interaction and communicator 5, and the Control Bionics NeuroNode trilogy. What occurred is this client was able to access a switch, but his access was very inconsistent because his motor movements were inconsistent. So he did appear to definitely connect his right arm movement with communication. That's what he'd been doing for such a long time, by going to access these step-by-step multiple message communicators. And but he really had a hard time consistently accessing the switch, even if it was mounted to his wheelchair and placed in an optimal position. We just kept having to move that around because of the inconsistencies in his motor movements and some involuntary movements that he was having. With eye gaze, he had some difficulty with maintaining his head placement upright and at midline, even with supports from his wheelchair. So oftentimes his head was down, or he might have been looking over at the system with his peripheral eye gaze. And so using head tracking and eye gaze after trials were not so fruitful for him. And he had actually tried some of these in the past, according to mom, without much success due to some difficulties with that head placement, despite moving the device in different positions. So then we tried the Control Bionics NeuroNode trilogy, and this was really fantastic because this system is called the trilogy because it provides 3 different modes of access. So eye gaze, touch, and then EMG or spatial control 3D. So what occurred is that the Control Bionics has a neuro node, which like circular looking node that has a neuro band. So you can put it on your arm and it almost looks like a watch. And that works like switch access, except it's on the person. So this was attached to his arm. Instead of him having to reach out to a switch to access it and then access his system through switch scanning and auditory feedback and highlighting, he was able to activate and start his scan just by moving his arm, because that neuro node was on his person, on his arm. So there were 2 ways to use the neuro node. One is through EMG, bioelectrical electromyography, where it's picking up the muscle movements. It detected even from minute movements, or spatial controls, where you're actually moving your body part or that muscle in space in X, Y, and Z axis. That's why it's called 3D. So what ended up working really well for this client is he had so much history of using his arm to communicate with his switches that he was able to use that spatial node. So he would, it was calibrated to his motor movements with his right hand. So he would lift his hand up to start the scan, listen to the auditory feedback of the choices, and then also moved his arm again to actually activate and produce the language that he wanted to do, access vocabulary on the device. So that worked really, really well for him. And it was so exciting because this individual is 23 years old and just had never been able to have consistent access, successful, consistent access to his AAC system. So he's doing really well. He came back for fitting sessions with us and has continued doing speech language therapy services with us. And he's using row scanning with auditory highlighting or auditory feedback, and sometimes does get his head upright and is visually scanning his system as well, and likes to chat about all sorts of things, and is also using a lot of accessible apps now, his favorite being Spotify. So he can now go through his system and access a accessible Spotify app and choose which song he wants to listen to and play it for all of us. So this was really successful in our opinion, and we're very excited that we were able to use this 5 Ps of AAC assessments as our guide to help recommend a system that's working well for this client. So thank you again for following along with me here. And hope you're able to attend a lot more ECHO series in our adult series with the UCF ECHO series webinars. Thank you.